Hello everybody in the room. So we are back for the second session of the live endoscopy course here from Milan University San Raffaele Hospital. We will start again from a connection from Hyderabad, from the Asian Gastroenterology Institute. I see Sandeep, who is waiting for us. So can you show directly to Sandeep? Sandeep, hello.
Hi, Paolo.
Hello.
Good afternoon.
Hello. We are ready to start. So you will be the first. Obviously, you are the star now. So we are going to present your case, and then the line will be up to you for your presentation. Thank you very much again to you
Paolo.
and the whole team in Hyderabad. You did a great job until now. Thank you very much.
So can we have the case presentation from that side? Okay.
It's a 61-year-old female with a recent onset of left upper abdominal pain and significant weight loss. CA 19.9 is about 1,500. A CT scan showed a 5-centimetric mass in the pancreatic body with vascular infiltration. EUS confirmed the lesion of the pancreas with FNA positive for adenocarcinoma. Here you can see the images from CT scan and EUS. And today's scheduled procedure is EUS guided radiofrequency ablation of the pancreatic mass, live from Hyderabad, Asian Institute of Gastroenterology.
Hi, good afternoon, and thank you once again for having us on this very important European EUS conference. So this patient, as you heard, do you have the EUS image there? Follow, can you?
Yes, we got it.
Okay. So we are on the pancreatic body, and Rajesh is helping me locate the lesion. You see the pancreatic body towards the genu side is quite okay. We see the big vessels, the superior mesenteric vein. And as I pull back gradually, if you see the PD, which is normal looking, I withdraw the scope back, and you start seeing a large tumor in the pancreatic body.
This is the whole extent of the lesion. You can see it's a fairly large lesion.
Yeah, if I torque around, it also has the duct which is dilated, starting from the upstream part of the tumor towards the tail. There's a little bit of trace amount of fluid around the pancreas. You can see a small, little crevice with fluid. Mic on up. Okay.
So
small amount.
Little bit of fluid is there.
So aim is to do a radiofrequency ablation. Unlike the ERCP way, we will do it the EUS way, and we'll get the tumor back. You see the splenic artery and vein in very close, almost the fat plane between the vessels, and the tumor is gone. So if I can have the room camera, we are using a special device for radiofrequency ablation. This is from Irby, a hybrid thumb probe. If Sridhar, can you take it out? Can you see this electrode which is peeping out?
Yeah, we see perfectly.
Yes, it's a bipolar electrode with the distal end is about 12 to 13 millimeters, and the proximal part is about 8 millimeters, with a central part which is 3 millimeters. The entire length of the electrode is about 25 millimeters. It has it's a marker, ultrasound marker in the proximal most part, which will tell us that the entire electrode is inside the lesion and not outside. The reason is that if the electrode is in the GI wall, there can be a perforation. Can you withdraw it back?
So it's a protective marker base.
This electrode is inside a sheath. Can you come back again? Which is a protective sheath. It's a transparent protective sheath, and the caliber of this sheath is 3.1 millimeter. So it can go through a a regular 3.7 or 3.8 channel echo endoscope, which I am inserting now. The whole length of the device is about 140 centimeters. It snugly fits at the hub of the electrode. The principle of movement of the device is quite similar to a regular EUS FNA needle. So what we are trying to do is adjust the sheath out. This is a crucial part, and there should be some time spent on this, because can you see, do you have the endoscopic image? If you can have the endoscopic image, you can see on the right upper part there's a transparent sheath which is projecting out.
Yes, we see clearly.
And we lock it here. So this protects the inner sharp electrode. Now what we will do is go back to the endosonal image, get the tumor in the longest possible axis, and pass this device quite similar to how we pass the FNA needle. And once we are inside, that's a needle which is coming in, avoiding the major vessels. I think it looks okay.
Yeah, that looks okay.
Okay, just let me recheck once. Yeah, that's better. If I can measure it here, so that will tell me the throw length of the needle which has to be coming out. That's okay, that's comfortable. This is 28.
28.
So it should be any tumor which is 25 millimeter or more can safely be ablated by this device.
Can you appreciate the needle there?
Yes,
Paulo?
perfectly visible.
It's little.
So it's a little thicker device. So Sandeep is trying to manipulate right into the heart of this lesion.
Okay.
I think you are in.
Yes.
Yes.
It's gone little bit towards.
So this is the active electrode, and
Yes.
The proximal ultrasound image is, this is from here to this part is an active electrode which is exactly inside the tumor, and I can reposition little bit, push and pull, and I think I'm quite
That's
nicely
right.
placed.
Yeah,
That's a very nice position.
Yeah.
You're happy, Paolo?
Yeah.
Because you are the main user of this.
If you do the
If I can-
procedures, I'm happy by definition.
Okay. So can you start the...
yeah, switch on the.
So just by pressing a paddle, it starts generating there's some connection.
Focus on the
No, no,
generator.
Now start.
Now it starts. If the cameraman can focus it,
So the lesion is, we
It
can
is
see the white.
it is
storm.
preset to 3 minutes. There are preset settings inside this RBYO 300. And
With
after some time of heat, we will see some air bubbles around the electrode.
Already there are few bubbles we can see.
Can you? Okay, that's great. So what's your results with this kind of device, Sandeep? Are you
So
treating?
this device is a palliative device to reduce the tumor burden. It burns the tumor by, you can see the bubbles which came up now.
Yeah.
Yeah, so more ecogenous white matter is coming all around the center of the electrode. So this device helps us in debulking the tumor by burning from inside.
Yeah.
We cannot burn the shell of it, outer shell, but the inner core can be burnt. It's a very safe and effective device, provided you're not going through a vessel or pancreatic duct. Because the two major complications which can happen with this electrode is pancreatitis if you have gone through a pancreatic duct, or a rupture of a blood vessel, either artery or vein, because they will burn a hole in it. As I see, while talking, I'm seeing the lesion which is becoming more white now.
Yeah.
And we have almost crossed half a minute, half the duration expected, 135 seconds over.
So you
And
can appreciate the whole of the
It co-
almost
Yeah.
the middle part of the central part of the lesion is completely ablated.
And
sir,
may I ask you, in your experience, do you have this kind of complication during the treatment in your patients?
no. So far we have not had any of these complications, but we are very careful of not avoiding the critical areas.
Yeah. And you, in the first case where you performed the biliary radiofrequency, you were mentioning about the possibility of this immuno stimulation by this kind of ablation treatment. What do you
Yeah,
think about this kind of treatment?
I guess once we burn the tumor, the antigens of the tumor get exposed. Immune reaction does happen, which has only been shown in the ex vivo studies and animal studies. But I guess some centers, including yours, are actively looking into it to look at the immune markers to show that also causes a second hit of cure. The
Yeah.
first hit unmasks the antigen of the tumor, and the second hit kind of helps in the. Is the time done? I think we're almost complete now. Yeah, that's
Yeah.
so.
Yeah.
And if I can just turn around. So immune reaction does happen later on. That's
Yeah.
exposing the antigens to the natural killer cells and the T cells,
It
which
seems
then come.
it seems that you have burned most of the tumor. It's just-
Yeah, so all these white areas that
Yeah.
you see are the burns area. This is coagulation necrosis. Over a period of next few days, this coagulum will liquefy and form a necrosis, which can be nicely seen on an MRI, diffusion weighted MRI, and the volume of the tumor vis-a-vis the volume of liquefaction can then be measured to see how much volume of the tumor has actually been ablated.
Yeah.
I'll withdraw the electrode back inside the protective sheath, which is now going back.
Now it's really well visible, the track and also the volume that
Yes.
that you have burned clearly.
Yeah.
Great demonstration.
Yeah, it looks quite okay, quite nice.
Yes.
And you can see the entire needle track, and the area around it, especially the central part, has more whitish areas. We can do a second session of RFA, not now, but maybe a few weeks down the line, and then reconsider in case the tumor is still there on imaging.
Okay.
With that, I think I would just like to show our unit once again. I thank Dr. Rangarao, our entire team of EUS, Rajesh, Mohan, Dr. Jahangir, Radhika. I think 2 people are working in the other room, and they are unable to come here. So thank you very much for giving us the opportunity to participate.
Thank you
in
very much
your-
from
Thank you, Paulo.
here. And may I say hello to whole team, because I've been there with you working for some days, and I met all of them. So I really feel at home when I'm with you. So thank you very much again.
Thank you, Paulo. And all the best for the rest
And
of the conference.
hopefully
Thank
we
you,
will
Paulo.
connect with you next year as well. So my greetings to Professor Reddy as well. Thank you very much.
Thank you.
Thank you.
Bye-bye. So guys, we're back in Milan, and we are ready to start the second morning session, and we are going to present the next case in room number 6.
Next patient is a 64-year-old male with medical history of appendectomy, HIV positive, red orchiectomy, and benign prostatic hyperplasia. In January 2018, for fungal infection, the patient underwent blood tests showing also an increase of total bilirubin and a slight increase of transaminases. Abdominal ultrasonography and CT scan were performed, showing a solid lesion of the pancreatic head, 3 cm, and a slight pancreatic duct and common bile duct dilation, with no vessel involvement. CA 19.9 is 88. Today's scheduled procedure is EUS and FNA and ERCP with biliary drainage with operator Dr. Iglesias Garcia and Professor Costamagna.
Hello? Can you hear me in the audience?
Okay,
Hello?
we can hear you and we can see you.
Ah, great.
Hello.
Well, I'm here with all the team, and here with, it's a big pleasure for me to share this case with Professor Costamagna. It's very, very easy to present Guido with all of his expertise. And we will try to make a team try to decide what is the best approach to this case, which unfortunately is one of the most common cases whenever we face a solid pancreatic mass in a clinical day-to-day routine. And I would like to highlight the big role of AUS whenever we're facing a solid pancreatic tumor. I usually do the same way as Anand showed you before. I love to start exploration from the stomach, mainly with the new systems that we have available today. I'm using, although I'm usually a pentax user, I'm using the new Olympus with the Aloca 850. So I always try to start the exploration from the stomach to try to see what I'm going to find when I'm going into the duodenum to see the head of the pancreas, because we always get a lot of information from the stomach. So this is one of my base landmarks, just exactly the same as Anand told you before, and we are facing the aorta. Let me see the pointer. So here, this is the aorta. No, this is the beginning of the celiac axis. So when I'm in this position, we have a big rate of hiatal hernia in Latin countries. So I usually want to go from the endoscopic image a little bit inside of the stomach, and then make a clockwise rotation to try to pull back again and trying to find my home land structure. So this is probably one of the best landmarks that we can have. We are just probably about 45, 50 centimeters away from the mouth. And we start to see here a lot of findings that is going to lead us with the diagnosis of this patient. So this is the PD, and we see that is absolutely abnormal. It's a dilated PD. So when now in this position, you have two options. You can do a clockwise or anti-clockwise rotation. If you go for an anti-clockwise rotation, you will go face into the genu of the pancreas. We still have the roll, the arrow in a very much dilated PD, so we can be following the PD with these rotations. We can still see the PD, and sometimes we can start to see what's going on in the patient. So we can see from the stomach that the patient has a huge mass in the head of the pancreas, yes. And we start to have very, very good referrals, because this is the SMV. So if this is the SMV, we can go facing the confluence, and we can also go and see the portal vein. Of course, you cannot only rely on your view of the big vessels from the stomach, but it starts to have you a lot of information. This is another nice image that we have with these high-resolution systems. We can see the bile duct, which is dilated, as we knew from the previous CAT scan reports. And we see a lot of sludge, probably because of the obstruction related to the mass that we are going to see in the head of the pancreas. So we've started the exploration in the stomach. We see a dilated PD, so we confirm. We've already saw the mass that we have in the head of the pancreas. I'm just trying to figure it out. Of course, we are going to see it better from the duodenum, but it's always important to have a first approach from the stomach. We will comment about some lymph nodes on the celiac axis, so I think this is an information that can be useful for the surgeons whenever they want to plan. Mainly, when we are facing a lesion in the head of the pancreas, it's important to know if they need to go up to the celiac axis, because although lymph nodes enlargement is not a contraindication for an attempt to R0 resection, I think it's very important to have a complete staging, including lymph node staging. So here we have the left kidney, so we now keep talking right in the clockwise rotation. We keep coming to the tail of the pancreas. So this is the spleen. We can make a small torque. Again, we can see the spleen. So this is the area to see the suprarenal gland, which is normal. And if we just keep torquing here until we go and see the aorta again, we can see the stations for the celiac axis, which should be all this area around. And we can see some ganglia here that usually we do not see this ganglia in a normal patient. So probably, as this has been reported also in the CAT scan, so we can confirm that the patient has some enlarged abnormal hypoechoic lymph nodes in the area of the celiac axis.
Which is not good.
Which is not good at all. So now we are going to go to the head of the pancreas, because we already saw the mass from the stomach in the head of the pancreas, but of course the duodenum is the best station to really see the complete full evaluation of the lesion. So now we are entering in the duodenal bulb, and now I'm showing with the arrow, this is the sludge inside of a very much dilated common bile duct. We can even measure And this is also a lot of information that we can provide to the guy that is going to do ERCP, if you're not the one doing the ERCP, because one of the good things of AUS is we can make the plan to the ERCP. So this is a 1.5 centimeter dilation of the common bile duct, which has a lot of sludge inside. So this is now the bile duct, we can use it as a referral, and if we just keep talking, we just see how the common bile duct ends in this big mass that we have. Now we can very nicely see here the infiltration of the common bile duct. We can also see this infiltration. This is another of the signs. This is one of the, probably this is the P duct dilated with obstructed by the pancreatic mass. And this you can very nicely see. I hope you can see in the audience as well as we can see here this huge mass that we have in the head of the pancreas. We can even measure it. We were discussing this morning about who is better to measure by CAT scan, by MRI, and by CT scan. At the end, I think it's a minimum difference among the different techniques. And we can see that this mass has at least 3.5, it's more than 3.5 centimeters. So we've just confirming the findings that we got in the CAT scan. We see a patient with a huge dilation of the CBD, dilated PD. We just confirmed the presence of a big mass in the head of the pancreas. And now the other good thing that we can do by AUS is not only characterizing. In this case particularly, I think BMOD is quite confident to have the diagnosis of a pancreatic cancer. But we can also have another very, very good information in these cases, which is the staging. So to optimize the staging of these pancreatic lesions. We can always take a look at these vascular structures. Here, just with a pointer. No, not just the pointer. Okay, here we can see this is the portal vein. So we can face the portal vein is towards the CBD. We can nicely see the confluence. This is the splenic vein, and this is the supramesenteric vein. So it's very important to follow the ducts and to see the relationship between the ducts, between the vessels and the lesions. But it's going to optimize the staging, the vascular staging, that at the end is the key part of the evaluation. So can we have this a little bit brighter? Because I think this is a... Okay, because at least we are in this particular part of the image, probably here. So if this is the supramesenteric vein, we see there is a loss in the interface between what is the mass and what is the lesion. So at least I cannot say that this is not resectable, but it's not a pure resectable. We were speaking about at least as a borderline resectable pancreatic lesion. So this is the first thing that can change our approach, because probably in this case with a borderline, we might think and discuss with the surgeons whether there's a case for neoadjuvant therapy or not. So this is something that was not clearly defined or depicted by the CAT scan, but we have nicely, so there is a loss of the interface between the pancreatic cancer and the supramesenteric vein, which at least give us the option to have a borderline and not directly resectable pancreatic lesion. So I will just try, because we've been here before and we have previously a very nice image of the mass, because we need to find a better position, because with the borderline there is an absolute need now to make an FNA, because we need to have histological confirmation to go for therapy.
Just in order to plan also the drainage, can you see exactly where the cystic duct is confluence with the cystic duct? Because we are planning to use a partially covered stent.
Okay, so this is one thing that we can. Okay, now wait, this is the.
I don't know if
sometimes it's possible, and here we can see. Well, probably this is the CBD, and here we have the cystic duct. Yeah. The problem is when it's so much dilated and with a lot of sludge, it makes almost impossible to see the distance between the beginning. Between the beginning of the ampulla and the real distance until we find. But we can just make an approach, because probably if we just keep talking until we found the mass, so probably this is where probably we should start the ARCP. This is the adrenal bulb. So if we can just probably stop, we know that we have a minimum distance between the mass, and probably it's about 3 centimeters minimum between the ampulla and the beginning of the cystic duct. This is something that we might and we should do more often, try to identify the different structures and of the common biota, because it's very important to plan which type of stent to be placed.
Yes.
So we are going to try to optimize the position to try to get better access to make the puncture.
Are you planning to do an FNA or a biopsy?
I mean, we have a different. We are in Milano. We have Professor Doglioni in Milano, and at the end depends absolutely in what's your approach with your pathologist.
Yes.
I mean, you have on-site pathologists, and there's a high suspicion of a pancreatic cancer. We usually go for a 25 gauge because it's less bloody. You have the enough amount of cells to get the diagnosis. Are for rows, for sure, of what I've learned from my pathologist is that 25 gauge needle is easier to interpret that you have a bigger sample like 22 and a 19. This is now, we do not know what's going to happen in the future with molecular testing and with dedicated medical drugs. Probably in that case we should change to a bigger sample. So probably this is a discussion to be done with the oncologist and probably with the pathologist to know how they can really get the better sample to obtain the biggest information. Today, with Professor Doglioni here in Milano, I think with a 25 gauge to confirm that this is a pancreatic cancer, it will be enough to go ahead with all of the different therapeutic options. We can also do a very nice Elasto evaluation here, because we expect this to be a hard lesion, as you can very nicely see. You need to have a very stable. We've learned this from Adrian, that if you have side movements, you might lose a little bit of the proper information on the elasto. And again, it's also important to, I'm doing more and more in the interpretation, and the best way and the best place to interpret the image is when the curve is going down, because it's when you have the optimal compression to have the correct elastographic evaluation. So this is, although we have some green spots inside, this is mainly a very hard lesion all over around, so this elasto evaluation will also support the diagnosis of pancreatic malignancy. Remember that with elasto we cannot differentiate different type of malignancy. We just can say whether the lesion is benign or the lesion is malignant. Is any comment in the audience, or we can go ahead, if Paolo, if the boss agrees, we can go ahead with the FNA?
Yeah, I definitely agree about the FNA, because this is a case of borderline resectable patient, and in our department, actually in our pancreas center, actually we have an ongoing trial, multi-center trial on the treatment of ablative treatment of borderline resectable. So probably we are going to enroll this patient for this kind of multi-center trial. So please go ahead in performing the biopsy, because our oncologists need for sure.
No, in our center we've also all borderlines. Even we are starting, I mean, there's a very nice trial that I know is going to come from Italy about neoadjuvant therapy even in resectable pancreatic lesions. And I just spoke to Professor Falconi, and the results are impressive. So probably
it's coming from our hospital.
Yes, I know, Paolo. That's why I want to highlight this study, because it's going to make a big change in the management of all pancreatic cancer. So it's not anymore just it's resectable and just sent for resection. We need to go on biopsy and also resectable lesions, because it seems there is going to be a big role for neoadjuvant therapy also in resectable pancreatic lesion.
Yeah, agree. So which kind of needle are you going to use?
Well, I'm going to go for a 25 because I have Professor Doglioni, and with Professor Doglioni, 25 is always a very good option. And also because the first impression is to have a pancreatic cancer. If we just have any findings suggesting another type of lesion, maybe I will think on using an histological needle. But this is, to be honest, based on Elasto, based on B-mode, based on all of the figures that we found in the case, I think this is going to be a pancreatic cancer. And in this case, with on-site, probably using a 25 gauge with rows, it's more than enough. And we all know that a 25 gauge needle is a very nice needle to use.
Yeah.
So I'm using the 25 Boston needle.
So we will stay with you for this biopsy and then go to another room.
Okay, I will just try. Okay. So okay, perfect. Just wait. I will always check for flow, but to be honest, I usually put the Doppler, but at the end I never trust very much in the Doppler because when you put the needle, you always have a lot of artifacts. So we will try to direct always in the view of Okay, so you see here that we have the tip of the needle in the middle of the lesion. So this is a nice position to start. So we just always drop again the stylet a little bit. This is a theory that I am not very sure, but it seems like we clean the tip of the needle from the contamination from the duodenal ball, but this is something that I've discussed with my pathologist, and he wants me to do it as a routine. And then we can do a slow pull, we can do whatever. I think that the key of FNA is to have the needle inside of the lesion. The rest, and if you have a good pathologist, the rest is really not so important. So we can do slow pull, for instance. So it's also very important to see the needle coming in and out of the lesion. I do not like very much to do very hard movements. I want to see the needle coming in and out with this small negative pressure. Yeah. So this is, in my experience, the best way to get the best sample. So you see the needle coming in and out. I mean, sometimes you might lose a little bit because of the small movements of the scope. So it's very important to use your arms to try to have the needle always in the view. Okay, here we are again, back and forth. I mean, these excursions, as Bill Brugge comments, this is called the excursions by Brugge, these to and fro movements. We just do as much as we can. Yes, we remove everything, and now I always give a couple of more shots when I got the stylet out, and I just take it out and remove it and send to Professor Doglioni to try to have the diagnosis.
So this was a nice case, I think, because you show clearly all what we have to show and to give in the report to the surgeons, to the endoscopists who are going to perform the RCP, or to ourselves if we are going to perform the RCP by ourselves, and what we need to give to the oncologist as well. Do you want, please, give a comment on the possibility to perform FNA or FNB for other kind of, personalized medicine, so genetic testing and so on? Do you usually perform another biopsy for this kind of testing?
Well, I can give you my experience in lung cancer, because we have a huge lung cancer unit, and more often we do FMBs always in lung cancer, because we always want to test, for instance, TTF1 mutations, EGF, the epidemiological growth factor mutations, because there is an upcoming need to personalize medicine. So the point is, in pancreatic cancer today, there is not this specific need, because we still need to know more about the behavior of the different types of pancreatic adenocarcinoma. We have data on the differentiation of the tumor and whether it's more or less differentiated. The response to chemo is going to be a little bit different. We will have some trials in the future, but it's true that, for instance, in lung cancer, it's key to do histology, because is the result of the FMB or the tissue acquisition is the one that is going to guide what specific type of oncological therapy the patient is going to undergo.
Okay. Thank you very much, Julio. We now wait for the report of Professor Doglioni, so stay tuned, and then you can start the RCP. We are going to present the next case in room number 5.
Next patient is a 69-year-old female with a medical history of atrial fibrillation in anticoagulant therapy. In January 2018, for the onset of jaundice and itching, she underwent EUS, showing a malignant lesion of the common bile duct infiltrating the pancreas, extended to the bifurcation of the cystic duct and to the common hepatic duct, 4 centimeters, with ascites and peritoneal nodules suspected for metastasis. FNA was not performed as there was an increased INR. Today's scheduled procedure is EUS and FNA with operator Dr. Opong.
Hi, welcome to room 5. It's great to be here again with the great team here at San Rafael. I have to share with you, I spent the first 5 minutes very confused and thinking I was losing my mind, but then I realized actually they had the image the other way around to what I'm used to, so we managed to get that straightened out. So this patient, as you've heard, I think she's also had some stenting done. There's a plastic stent in that may have been placed at percutaneously, I believe. I'm just trying, this rather unstable position, and I'm just trying to get back to show you some of the findings down in the duodenum. The most salient findings, I'm just going to try and position myself close to the ampulla. So on the endoscopic image, you can see the stent there, and I'm just going to try and place the instrument there, because just in the uncinate, just inferior to the ampulla and inferior to the main lesion, there's actually a little cystic lesion that we've been examining, if I can find it back again. So I'm just slowly pulling my scope back. The problem I've had is it very quickly is falling back round and into the duodenum and actually into the antrum. But I'm quite keen to show you this small lesion if I can. So, oops. Okay, let's just orientate that round. So here we are. So I think I'm demonstrating to you, where's the pointer? We're just seeing the Luca here from Hitachi's helping me. We're using the Aloca Areta V70, which is the latest machine, but not one I'm completely familiar with. So just come back. So we were just below, we could just see the pancreatic duct on the screen there, but just below it, if I can, without the, I wanted to try and show you this small cystic lesion. I think that's the main lesion coming into view there. Sorry, just get the pointer. Just in this area here, but actually just below there, we had a view where we could see the pancreatic duct, and if I can't demonstrate it, there was actually a small, about 1 centimeter cyst with a nodule or a mucus plug within it, and I think that's potentially relevant. So coming back, I shall focus maybe now on the main lesion, and hopefully can demonstrate the other lesion to you later. So here we go.
Is it just the position, or do
You
you
just
think
have
the
to bear
stent
with
is
me.
also providing some interference?
I'm just going to come back. So when I'm having difficulty getting the position, what I tend to do is try and come back to the duodenal cap and start again. And actually, as you can see, I was a little bit further down than I thought. So I'm just going to pop back into the duodenal cap, just to there, and then let's just orientate the structures. So putting the color flow Doppler on, I think we're finding the portal vein there. Go back onto the B mode, and I'm just rotating down clockwise, putting the small wheel forward, and just really trying to locate this area that's causing the problem. And I'm just pushing in a little bit further down, and you are seeing there's some hypoechoic area coming into view. And actually at the top of the screen, you can see the what I mentioned before. So there's this small cyst with a lesion within it, and I'm going to use the E-flow, which is the new variation of fine of the fine Doppler that Hitachi Aloca have developed, which is said to be an improvement on the previous one. So I've seemed to, there we are, just to see if we can detect any flow within this, but there isn't any flow. I don't know, any thoughts from the moderators or the audience as to the nature of this lesion? I mean, it's incidental and it's not the main lesion, but it may be relevant to the underlying pathology. Okay, if we come back off. So I'm going to change my depth now. I'm going to maintain my focus in that field area there, which is where I think the pathology is, and I'm rotating clockwise. I think we're now seeing the can I have the pointer, please? Sorry. I think that's the pancreatic duct coming down there. This is the area of the CBD, and you can see it's quite abnormal. There's some cystic solid changes going on there, and there's also a stent in situ which we're not quite seeing, and now we're getting a better idea of this area, which I'm just going to freeze, and get a measurement. So we're not seeing that posterior margin so well, and it's difficult to judge the exact distance of it, but at least 37 millimeters in that direction. And just come around there a little bit. So we're getting a better idea of some solid areas just there. Now what I'll do is I'm going to go back into the stomach. I want to show you the area of the neck. Gain. Yes. Yeah, okay. Okay, sorry, just hearing from Paolo that the image is a bit too dark. Sorry about that. So we've just adjusted that. So I'm now coming back. I want to show the area of the neck of pancreas where we were looking at some cystic changes before. So I'm rotating counterclockwise, so going down, hopefully show you the confluence. So there's the confluence, and then rotating clockwise, and as we go round, we're coming into this cystic area here within the sort of body of pancreas. So there is obviously cystic changes in this pancreas, changes here in the body, neck of pancreas, and then the main lesion that's in the head of pancreas that's caused the biliary obstruction. So in a case like this, I think we've already been told about the peritoneal deposits. We've already been told about some ascites, which I saw earlier. And so in my normal practice, I would really be focusing now on getting some tissue, particularly as at the Freeman Hospital where I work. We unfortunately don't have access to propofol for many lists. So when the instrument's down, the focus really is on getting the tissue.
Kofi, what's your next step now?
So I'm going to go back down to the duodenum, and I'm really going to focus on getting a biopsy or an FNA. And we discussed this obviously quite a bit yesterday. So in my institution, we don't have any sort of on-site cytopathology. We don't have anybody like Professor Doglioni helping us. So we would be using a shark core needle, doing an FNB, and sending that off in formaldehyde. But obviously, I think, hello?
I think that you can use shark core maybe 25 or 22,
well,
and then we can have the cytology.
Well, what I was going to say is I think I'm a strong believer that you actually play to the strengths of the pathologist. So I think FNA needles, I gather, are the preferred needle. So we've actually got a Boston Scientific FNA needle, I think, open and ready for us here. So I think that's the one we're going to put down.
Okay.
So, thank you. So I'm using the slim scope. That's the other thing to say, which I think has a better ultrasound image, and to some extent some of the handling features are better than the therapeutic scope. And again, in my practice, because we're doing it often under conscious sedation, the patient comfort is important, and the size of the scope is relevant there. So we're just getting the needle down, which has gone down very easily without any difficulty. And so now we're back in this area where I demonstrated to you that small cystic lesion. And I think you did the original EUS, didn't you, Paolo?
Yeah, I did. And this is a pity that you have the catheter, the drainage inside the biliary tract, because the lesion in the previous EUS procedures was easily and very well seen inside the common bile duct, going outside then when the big lesion was.
Yeah.
So I think that this case could be a case of cholangiocarcinoma, in a case of probably APMN, both for common bile duct and pancreatic duct.
I agree. It does seem to be that way. I guess the advantage of having, you can see here, the advantage, I guess, of having the So I'm just getting the pointer. The advantage of having the stent in situ would be that, I think you can see that, I think this is the tissue that's extending out with the duct, is that the concern obviously when you're doing an FNA procedure in a jaundice patient is, and you're going to traverse the duct, is to ensure that you're able to get them drained promptly. So I'm reassured that the patient is it has got a stent in. So I'm just...
On the other hand, the problem of having stent, if when you have a very small lesion, sometimes you don't. And you show yesterday your data. Was this nice paper, this nice oral presentation from your institution, and showing clearly that how the stenting in place impact on the quality and the adequacy of the specimen.
Yep. So I've got I keep losing my pointer, sorry. There. So I've got the needles there, and obviously this is the area that I want to puncture. So I'm going to have to and I've got the sort of the bridge on, so I'm just going to pull back slowly, but I'm also aware that it tends to fall out. Obviously going to use a Doppler first to make sure there's no significant vessels in view, which there aren't. And I've now just got the needle just there. And it's not quite the direction I want, so I'm just going to pull back a little bit. I think that's some of the area that we're interested in. And it's slightly awkward. Again, it's not quite... Here we are. Just used my color flow again. Okay, so I'm going to go into this area here to start with. Okay, and we'll just put the stylet back down. I'm going to pull the stylet out. And in my practice, I tend to use suction. There was a discussion yesterday about that. It's probably more from just what I'm used to doing over the years. And so we're going to apply some suction. And then obviously the important thing is to try and fan as much as possible, varying the depth of the needle in the lesion and keeping the needle occasionally at least in view so that we can make sure that we're not going too deep. And there's sort of, the needle's handling very nicely, but it is quite a firm lesion. And I'm rotating the scope, trying to change the position as much as I can, and also using the bridge and the big wheel to try and change the position, although it's probably not changing a huge amount currently. I think I'm probably happy with that number of passes, and we'll now bring this out.
Okay, coffee?
Hi.
Okay. While you prepare for Professor Doglioni's specimen, we go in the pathology room because Professor Doglioni is ready to present us the results in Julio room. So we will be back to you, so stay tuned. Claudio?
Hello. This is an interesting, peculiar case, I think, because the images were of that of a pancreatic adenocarcinoma, but I think in these cases is a neuroendocrine tumor, but probably a malignant one, because it's difficult to see on the screen, probably because the material, the cells are embedded in the clots, but these are quite monomorphous, very dark staining, the nuclei, and some mitotic activity. So I would suggest neuroendocrine tumor, possibly malignant, possibly neuroendocrine carcinoma. Yeah.
Thank you very much, Claudio. Thank you very much. So great demonstration. So we are changing now the diagnosis of this patient, and so now after we go back to room number 6, we would ask a comment to Julio and to Guido. But now we are going to present the next case in room number 4.
Next patient is a 77-year-old male with a medical history of iodinated contrast medium allergy. In August 2017, for episode of mild acute pancreatitis and weight loss, the patient underwent MRI with dilation of the pancreatic duct at the tail, 8 mm, and of branch ducts. EUS set as suspicious for mixed type IPMN. FNA was inconclusive. In January 2018, for mild persistence of hyperamylasia and hyperlipasia, AGG4 dosage was normal, and currently there was no further weight loss. MRCP showed a stable dilation of a pancreatic duct and branch duct in the tail of the pancreas with suspicious stricture of the body. Here you can see the picture from the MRI, the stricture, and here the dilation of the pancreatic duct and the branch ducts. Today's scheduled procedure is EUS with FNA with operator Dr. Petrone.
Hello? Can you hear me?
Yes, we can hear you, Mara.
Okay, hello to everybody. I'm using a standard linear probe from Pentax, the UTK, with the Narietta V17 system. I'm the moment with the probe is in the second portion of the duodenum. I was just looking for any lymphadenopathy peripancreatic or between the aorta and cava. You can see here, this is the head of the pancreas with this kind of parenchyma that looks like chronic pancreatitis because there are many hyperechoic strands, there are some lobularity, there are some hyperechoic foci, and I don't see any focal lesion in the head of the pancreas. And it is always important to remind that we have to be sure to see all the pancreatic parenchyma, and we have some special landmark that we have always to find that are the mesenteric vessels and the bigger vessels, the aorta and cava, just to be sure that we are able to see all the head of the pancreas. So pulling back very slowly the scope following the mesenteric vessels that you can see here, we have the head of the pancreas here, and the first duct that we can see is the pancreatic duct that is not dilated, and then the CBD here, very thin without anything inside. So we pull back the scope. I would say that it looks like a chronic pancreatitis. So there are different findings of chronic pancreatitis. Now, moving back with the scope into the stomach, going to the tail of the pancreas, where the CT and MRI describes the dilation, I would like to start directly from the splenic hilum. So we have here the spleen. And if I gently rotate anti-clockwise, you can see here the splenic vessels. And I look for the distal part of the tail of the pancreas. Here we are. So here we can see a dilation of the pancreatic duct. We can zoom a little bit the image. There is a dilation of the pancreatic duct and also of many branch ducts with some atrophy of the parenchyma. And we can also see, if you put some attention more, a thickening of the wall of the pancreatic duct with something inside. Okay, this seems to be like a nodule. And if we rotate towards the body of the pancreas, we can clearly see a solid lesion. So the patient has a focal solid lesion of the body of the pancreas, and of course there is also a dilation of the pancreatic duct of the tail. And only just look some seconds more to this image. If we have a features like this, with the dilation of the pancreatic duct, dilation of the branch duct, some small nodule inside, we have to think about an IPMN, considering both the main pancreatic duct and the branch duct. But in this patient, we have also a solid lesion. You see, you can see here there is an hyperechoic portion of the lesion that probably is a mucinous component of the lesion. And then, more closer to the splenic vessel, there is this hypoechoic, more solid lesion. So I think that now the patient has an IPMN that is completely degenerated, so we have a cancer. And I would like to perform the sonoview, the contrast, because I'm quite sure that the distal component is more like mucus inside, with the dilation of the pancreatic duct here, and then the solid component here that we are going then to puncture. What do you think about from the audience? Can you hear me?
Yes. Can you hear us?
Okay.
Yeah. Yeah.
So there is
no,
also...
I'm just looking.
Yeah, sorry.
No, that's okay. I was saying I agree with your assessment, looking at this. It's interesting that on the MRI, it showed up as just a stricture, but when you do the EUS, you can clearly see that there's actually a solid lesion there.
Yeah, exactly. And there is also the involvement of the splenic vessel, both the vein and the artery. You can see here also, there are some calcification, of course, in the distal portion of the lesion. And the vein is completely inside, and also the splenic artery. Okay, so now we set them. Yeah?
Mara, we leave you for just 2 minutes because Professor Doglioni needs to show us the results of the biopsy that Kofi has performed 5 minutes ago.
Okay.
So, Claudio? Claudio? He's looking for the microphone. Okay.
You hear me?
Okay, Claudio.
So this is a classic picture of pancreatic ductal adenocarcinoma. So you see an aggregate of neoplastic cells embedded in a very large quantity of necrotic material. So in this case, the diagnosis is easy. Yeah. At least for the cytological point of view, okay. Of course.
Thank you. Thank you very much, Claudio. So we can go back to room number 4. Mara?
Yes, we
can
are.
You hear us?
Yeah.
Okay.
We are ready for the sonoview, so we are going to inject the sonoview right now. Then we can start with, we can start with the counter. And just a few seconds, we are going to check for any enhancement inside the lesion. We will already see the splenic vessels with contrast inside. Okay. So I would say that in the arterial phase, this part is completely hypoenhanced. And if we go to the distal part of the tail, where we saw the apoechoic material as well, we don't see any small vessel inside. Okay. So for sure we have to biopsy this lesion.
So Mara, just to resume the case, we were starting the procedure thinking about a very short stenosis of the PD and the dilation of the PD behind that, seen at the CT probably, I don't remember. And now the EUS has depicted a solid focal lesion.
Yeah, exactly. So I was waiting for a cystic lesion or mainly only for a dilation of the pancreatic duct, but now we have a solid lesion. And this is very important to underline because if the MRI is not conclusive or the CT scan has any doubt, we should always suggest an EUS. And if the FNA is not conclusive, probably it's better to repeat the procedure if you have any suspicions of a focal lesion, or also send the patient in the experience center, because the patient underwent US 6 months ago, and probably 6 months ago was a little bit different. So
this is a very important thing to show, because as yesterday we have shown during the oral presentation that in 12% of the cases, CT scan doesn't see the lesion, and the US is positive 100% of the cases. This is a very clear message to be given. So if you have not a clear CT scan or not a clear MRI, US actually is mandatory, because you can depict a small lesion, and in this case, this is a small lesion significantly invading the vessels, I think. So it's very important, the message that you are giving, actually.
Absolutely.
So
And
you can perform the biopsy. Which needle are you using?
I'm going to use a 25 needle, a slim line from Boston. I would like to go in the more hypoechoic part, because should be the most malignant part. To be honest, I have to say that I saw also the image of the US that the patient performed in another center, and probably the lesion was already it was smaller, of course, but already there. So sometimes we have also to ask for some help for the cytology, you know. Okay, the needle is inside. We can remove the stylet with the slow pull technique. We have always to check for the distal part, the tip of the needle. Just some movements, and I would say that is enough. Okay. And looking for the vessel, so the spleen and the vein and the artery are both involved. So and the patient, I don't remember the age, but almost 17 years old. We can discuss now about the treatment. Yeah.
Yes.
Mara,
scusa, Francesco speaking. In your practice, do you think that the elastography could guide the site of the puncture?
I think that in this case should be very nice to use. I try before the connection, yes, because of the different kind of lesions. So this part closest to the body of the pancreas is more rigid. And now if we have a nice image like this one, we can look for any histogram. So you should involve all the rigid area. And we can also perform the same thing on the body, on the tail, sorry. So this is dilation, so it's not the right position. Okay, just here, there is the fourth nodule that we can see in the tail.
So you trust more the information by elastography instead of contrast medium for the to target the lesion?
I don't say. I would say that we need both of them.
Both.
And also the B mode alone, because in this patient it's quite clear the difference of the component of the lesion. But in our daily practice, I have to say that we use both. So the elastography and the contrast in most of the patients, just to be sure to target the lesion in the best position. You can see this area really hypoechoic, where I performed the FNA. Now we have to wait if it's positive or not. I hope so, but seems to be the most malignant part of the lesion, if compared to the tail here. Do you agree, Francesco?
Yes, thank you. Yes, definitely.
You can see here also that probably sometimes we can see better in the dilation of the duct, some irregularity inside, some small nodules.
Ok, siamo pronti che andiamo in sala.
We check always for any lymphadenopathy, also for the celiac trunk, like here. We have always to check for any lymphadenopathy, and we always have to report if there are any suspicious lymphadenopathy. So we have the celiac trunk here, the superior mesenteric artery. I didn't see any malignant lymph node.
Given that I think this patient did have a history of pancreatitis, is that right? Do you think there's any role for ERCP to decompress?
Do you think, sorry, what, Amy? I didn't hear you.
Oh, sorry. I was just saying if this patient had a history of pancreatitis, do you think there's any role for ERCP?
Oh, no, I would say no, there is no role in this case. He has a pancreatic parenchyma in the head of the pancreas, like pancreatitis, but I don't think that in this case is absolutely unuseful, in my opinion. I think that we almost have, we can perform another passage just to be sure that Professor Doglioni has enough material. And if you have any question, or if we can, grazie.
Mara, is there any kind of ascites? Have you seen if there is ascites? Because usually in this case, it's small lesion close to the tail. Sometimes you find out small amount of ascites, as Hanan told yesterday.
Yeah. There is something probably just here in the posterior, between the posterior gastric wall and the lesion. And there are also some hypoechoic digitation going through the gastric wall. Yes.
Okay. So thank you very much, Mara. While we are waiting for Professor Doglioni, so stay there and do the second pass if you want, or stay there waiting for Professor Doglioni report. We go back in room number 6 because I've seen that Professor Costamagna has started the ERCP. So Guido and Julio, we are back with you. So first of all, I would ask to Julio to comment the results of the reports of Professor Doglioni, if you want.
Yes, can you hear me in the audience now?
Yes, we can hear.
Yes, this is one of the good things of the needs to do an FNA, because the final result was not what was expected. It was not a pancreatic adenocarcinoma, but it was an endocrine carcinoma. It was a malignant endocrine carcinoma, so probably this is going to change a little bit the therapeutic approach, both from the oncological point of view, from the surgical point of view. And just before removing the scope, when we were finalizing the US, we also saw a little bit of ascites that I saw Professor Costamagna. So this is really a tricky case because it's not the typical pancreatic cancer, although B-mode, CT scan, Elasto also show malignant. But that's why it's so important to make an FNA, because at the end the tissue is the issue, and in this case it was very important. And now is the time for Guido to try to drain, because there is a very lot of new decisions that are on the go according to the diagnosis that we have already had.
Exactly. So I have just passed the scope, and you see that the papilla here is quite normal. We had the impression that it was enlarged, and actually it is the minor papilla which is enlarged.
Exactly.
You see here? That's the minor papilla. Quite huge, bulging. So it could be due to the tumor. But it could also be to a pancreas divisum, where usually the minor papilla is bigger. Not always, but in any case, this doesn't make any difference in what we will try to do.
Guido?
See?
Sorry, we go in the cytology room for 1 minute for the diagnosis of the lesion that Mara has just biopsy. So give the line to Professor Doglioni and then we'll be back to you.
So I wait for you.
Please.
So, the last case is quite similar to the previous one. As you see, a large fragment of neoplastic cell, very irregular nuclei, varying in size and shapes, and a background of necrotic material. So the diagnosis is again pancreatic ductal adenocarcinoma.
So thank you very much, Claudio. Thank you. Before going back to room number 6, we'll go back to room number 4 because I've seen that Mara shows something in the liver. Can you show us, Mara, what have you seen and comment what you're feeling?
I was just checking the left lobe with this small hypoechoic lesion. I have some doubts about that.
But it looks like more like an angioma.
An angioma, yeah.
Okay. So thank you very much, Mara. Thank you very much.
Thank you.
For all the team. So we will go back to room number 6 because Professor Costamagna is ready to cannulate. Okay, Guido?
Yes,
Thank you very much for waiting for us.
No problem.
You are the last case, so take all the time that you need.
Okay.
So not 5 minutes.
So when you have to cannulate a papilla, virgin papilla, first important thing is to look at the papilla very closely, because sometimes you can have hints where to look for the common bile duct. And if there is a small ectropion, like in this case, like in this area, you see here, most probably the common bile duct will be there. So, of course, if you see some bile coming out, it's even better. But in this case, there is a complete obstruction, and therefore there is no bile gushing out from the papilla. So can you tender un pochino? So I will try, first of all, to see this area. You see there is a small ectropion. And now I will try to inject a little bit of contrast. You see? See? And that's the bile duct, you see? Okay, I'm already deep into the duct. So we can pass the guide wire immediately.
Can we see the x-ray? Right now we're just seeing the endoscopic view.
So in this case, the anatomic indication was important.
Perfect.
To see where the bile duct was. You see the sludge inside. Okay, we are over already, not in the intrahepatic duct, probably the cystic duct. So I will go through the stricture with my cannulotome, come back and try again to find that's the cystic duct probably. Okay, I change my position, again that's the cystic duct. Maybe andiamo di spalla. That's already the cystic duct. Maybe we can inject some more contrast to see the anatomy. In this case, puoi iniettare un po' di contrasto? I want to be very stable into, you see, that's the cystic duct probably. So I come back, down, and then we will try again. I will change, by moving the scope, the axis of the cannulotome. And, okay, now you can go up. Su con la guida, basta contrasto.
It looks like there might be a small filling defect just
It's
above the
again
stricture.
the cystic duct. Torna indietro. Cerco di salire io. I try to follow the bile duct with the cannulotome in order to have another change. Now I go again into the cystic duct. It's a tricky situation. Of course, we can also use this. Basta contrasta. Solo, you see the cystic duct quite well now with a gallbladder. So, proviamo di nuovo. Sì, scopia. Again, no, questo è il cistico. I'm torquing the scope in order to get another axis. No, il cistico ancora. Cistico. No. I come back. Yes, adesso. Cistico. Sempre il cistico. We will try to make a loop. Prova a fare una loop sotto il cistico. Adesso spingi. No. Sì. Spingi che andiamo su di qua. Sì? Fai il loop. No, it's always the cystic duct. Okay, we can also release the stent by using the cystic duct because the cystic duct is the implant is high enough in order to not to be involved in the partially covered stent. We have chosen to use a partially covered stent. Now the
Guido,
axis is always the same.
Guido, may I ask you,
Sì?
Can you hear me? May I ask you,
Spingi la guida su più che puoi.
are there really solid data that show that if you put a cover stent covering the cystic duct, you increase the risk of cholecystitis and so on?
No, actually there are conflicting results in the literature. Of course, at least theoretically, you increase the risk by closing the cystic duct, but actually in the literature we have conflicting data. So
I mean, what's your standard policy in this case?
I don't care very much. So put the più su che può. Sì, scoppia? Vabbè, basta così. So now we will perform a small sphincterotomy, and I will use the new Vio-free generator from Erbe, which apart from the nice screen, which is a touch screen where you can modify the settings, the real change is the heart of the generator, which is much more precise in detecting the resistance of the tissue and giving you a fantastic feeling of what you're doing. So in this case, I will use the usual setting for sphincterotomy. Now, with the only 1/3 of the wire inserted, so probably a few millimeters, I block the sphincterotomy with my elevator, and I will use my right hand on the shaft of the scope. You see, by torquing the shaft of the scope, I can modify the direction of the cut. So what I call the cello player position, you see, like a cello. Okay, that's enough, we don't need more. and now we will place the stent. So let's try once again to get another direction, maybe without the sphincteratome, which is inducing the guide wire. Lasciamo la guida. It's a rapid exchange system, so we can leave the wire, the short wire. Okay. Screen. Scopia. Okay. I'm removing the cannulotome, the ototome from Boston Scientific. And okay, now we leave the last few centimeters, and again I can block. I have two ways of blocking also with the elevator. It's a V-scope, so the position of my guide wire is very stable. Una garzina, grazie. And now we will place the stent. We have chosen a 90S partially covered 6 centimeter long stent from Taiwan. Okay, you can open the stent. Usually 6 centimeter is the usual length for pancreatic cancer. 4 is usually a little bit too short. Okay, now Marta is opening the stent, flushing with the saline the delivery device. We don't need to dilate, and even sphincterotomy, I prefer to do always a small sphincterotomy, but there is no evidence that this is necessary.
Is there any specific indication for you to use a plastic stent whenever you're standing today a pancreatic tumor?
That's a good question. I think that in case of pancreatic tumors, there is no more indication for plastic stenting unless you don't have a final diagnosis. Because even for preoperative drainage in operable patients, probably metal stents perform better. We are now conducting a randomized prospective study comparing no drainage to drainage with metal stents. You know that the paper published by the Dutch multi-center study in the New England a few years ago showed that preoperative drainage is not necessary in pancreatic cancer. But it was done with plastic stents, and now we are repeating the study with metal stents, and apparently the results are different, are better. So can we have a look at the X-ray? Okay, you see the stent is in place. I come back a little bit with the wire because I don't want the wire to be catched by the stent. Okay, we can start opening. You see the yellow marker here, which is in good position. The stent will shorten, of course. Okay, see? So I release my elevator, and I try to keep, see? The yellow marker outside the, okay, okay. Okay.
Can we see the X-ray?
X-ray, yes, okay. Let's go. Let's go. Let's go. I want the stent to be level with the papilla, which is nice like this.
Very good.
And now we will see the sludge coming out probably. You see there is a dirty bile. Can we have a look? Okay, the stent is below the cystic duct insertion.
Vediamo adesso l'immagine radiologica.
So, X-ray? Okay. Just in case we can use the insertion catheter to wash the bile duct if needed, but I don't think so. It looks like there is a good drainage of bile. So I think you see now the sludge is coming out. You see?
Yeah.
Maybe you can put some saline, un po' di soluzione fisiologica, sì. And we will wash. Perché no? Da qui.
Okay.
Okay, so I think
great.
you see the interior part of the stent here, and I think we are done.
Yeah, I agree with you.
Okay.
Thank you very much, Guido. Thank you very much,
welcome.
Julio.
Thank you.
Great demonstration. You were really too short, but anyway, we are going to have lunch before earlier. So it's noon, so we will go back and start half an hour before. So we will start in 1 hour at 1 past 30. So
Okay.
30 past 1, okay?
Okay.
See you.